A 62-year-old woman complains of low back pain and perineal pressure for 1.5 years. Now, she's 62 years old. Most likely, she is postmenopausal. She has been prescribed a pessary. Now, what is a pessary? I'll show you some pictures of this. This is a device which is placed into the vagina to hold the organs into more anatomic position. But she doesn't want to wear it. On pelvic exam, she has a 2nd-degree uterine prolapse with cystocele and rectocele. So she got a package deal. She's got uterine prolapse, cystocele, and rectocele. Anatomy. When we look at the pelvic floor, we can divide the pelvic diaphragm into an anterior and posterior triangle. This is the anterior and the posterior. The anterior triangle is penetrated by the urethra, which is the urinary tract, the vagina, the reproductive tract. The posterior triangle is penetrated by the anus, which is the gastrointestinal tract. So we've got 3 organ systems in the pelvis. We have the urinary, the reproductive, and the GI tract. So it would make sense that if we have pelvic relaxation, if we have pelvic prolapse, that we are going to affect the urinary, the reproductive, and the GI tracts. Etiology of uterine prolapse. There is general agreement that it is probably most common related to childbirth. Now, that isn't to say that there are not genetic factors which may very well be participating, but when you look at the childbirth and the trauma of distension and the mechanical trauma, it's easy to see why you could have injury. And when you push a 9-pound baby through a pelvic floor, injury is not uncommon. That may not show up until years later. We'll talk more about this with elective cesareans. Classification of uterine prolapse. I want you to notice the usual right angle relationship between the uterus and the vagina. This is a normal, healthy relationship. Notice as you start to get uterine prolapse, this is the normal angle, which is a 90-degree angle. As you start to get uterine prolapse, notice how the uterus changes into the same plane as the vagina. You see that? And then as we start to get descensus, or lack of support, the uterus starts moving down and down and down until it's outside of the body, wrapped up in the vagina. So we have early, 1st degree, 2nd degree, 3rd degree prolapse. When it is almost out of the body, the uterus is called proxidentia, marked prolapse. This is the introitus. Here you can see is where the cervix is. Now, the cervix should be at about this level. So this is early uterine prolapse, but the cervix has not come to the vaginal opening. Here we have grade 2, and you can see that the cervix is now at the vaginal opening. When you have proxidentia, the uterus is hanging right out, and here is the uterus, and it is wrapped up by the anterior wall of the vagina and the posterior wall of the vagina. This is prolapse. And what we're seeing is the inverted vagina. These are the vaginal epithelium. This is the columnar epithelium of the endocervical canal, and you can see the difference in color between the columnar epithelium and the stratified squamous epithelium, which is out here. This could also represent an erosion or a wearing away of the columnar epithelium. And what we've got here then is exposed stroma. This is complete proxidentia. So that was uterine prolapse. Now we look at vaginal prolapse. If it is the anterior vaginal wall which is involved, we call this a cystocele, and within this prolapse is the bladder. If it is the posterior vaginal wall which prolapse, we call this a rectocele, and contained within this prolapse is the rectum. If there is a prolapse of the pouch of Douglas, I'll show you what that looks like. We have within that the small bowel, and this is called enterocele. And the typical frequency or the prevalence, cystocele is the most prevalent, followed by rectocele, and the least common is enterocele. And I don't have any good explanation why the cystocele is the most common. Okay, this image shows the cystocele. This is a sagittal view of the pelvis. You can see here is the uterus. This is the vagina. Notice the uterus is in the same orientation as the vagina. This is the rectum. This is the prolapse, which is right here, the anterior vaginal wall. This is cystocele. And you can see as she increases intra-abdominal pressure, we get prolapse of the anterior vaginal wall. I want you to notice where the pouch of Douglas is, which is right here. This is where the enterocele small bowel will come through. This is a photograph of a cystocele anterior vaginal wall prolapse. This is mild. Now, this is the posterior vaginal wall. You can see the anterior vaginal wall and the bladder are well supported. Here is the uterus with the endometrial stripe. Notice the posterior vaginal wall is what's prolapsed. This is seen on pelvic exam when she increases intra-abdominal pressure. Now, one of the main symptoms is the patient says, I cannot empty all the stool out without putting my finger in here and pushing the stool out, because it gets caught in this cul-de-sac and the sac here and it can't get out. So the stool collects in there. The patient has to put her finger in. Digital splinting is what this is called. And here you can see a rectocele. I want to come back and notice the pouch of Douglas is right here. Small bowel can get between the uterine wall and the rectum. Notice what happens with the enterocele. Between the posterior wall of the uterus and the rectum, if there is prolapse of the pouch of Douglas, small bowel gets in here. This is peritoneum, which is coming out. This is called enterocele. This is the least common of these three. This is actually prolapse of the vaginal wall after we've got a hysterectomy which is performed. So this is prolapse of the vagina. The diagnosis is made at the time of pelvic exam, as we discussed. Have the patient Valsalva, increase intra-abdominal pressure, and then look for prolapse of the vaginal walls of the cervix, the uterus, and the rectum. Cystocele. You can't miss this. Now, is this a life-threatening problem? No, but it's a matter of quality of life. Management. It could be either surgical or medical. Medical management includes Kegel exercises, estrogen replacement if she is postmenopausal, or it could be a vaginal pessary. Let's talk for a moment about Kegel exercises. This is from our local medical journal called Red Book. And I want to direct your attention to this article right here. 6 little moves to make your love life hotter. And what do you think this is talking about? Kegel exercises. This is what it's talking about. As you get control of the pelvic muscles, you can lower the threshold for orgasm. And almost every Red Book, Cosmopolitan magazine is going to have Kegel exercises in it. the muscles of the pelvic diaphragm can get weak. And this, I noticed on the internet, is Aquaflex pelvic floor exercise cones. What the woman does is she puts these in the vagina. You can have differing weights depending on how strong the muscles are. And you have easy cord. You have a string coming out for easy removal. Progressive weights. And as you get more control, you can have heavier and heavier weights. This costs $79. Here's another one. Kegel cones. Pelvic floor exercises. Very similar. They're weighted vaginal cones, and you put them in the vagina and keep them from falling out. The muscles that you use for the Kegel exercises are the same ones as you use to hold a urinary stream from coming out. Okay, vaginal pessary. Notice all these different kinds of pessaries, different sizes, different shapes, and all of these are devices placed in the vagina. Here we have a round donut, which is inflated. This is called a gel horn pessary, and this is a cube, which is placed in the vagina, and here is a string to make it easier to take it out. This was an interesting internet site advertising for Fembrace. What's it for? For genital prolapse, prolapse uterus, cystocele, rectocele, enterocele. What else will it take care of? Why, it will take care of varicose veins on the vulva, prolapse uterus, backache, hip pain, leg pain, pelvic pain, urinary frequency, fatigue, almost anything that is bothering you. Why, you just get a Fembrace. What do you think of that? Well, I don't know. But there it is. So this would be medical management. Surgical management, if there is prolapse of the uterus, we would do a vaginal hysterectomy because you've got good access to the uterus because it is already prolapsed down. If it is vaginal wall prolapse, we can do a colporrhaphy. Colpo, vagina, orrhaphy is repair. So we can do either the anterior vaginal wall or the posterior vaginal wall. This is an anterior colporrhaphy. And you can see you incise, make an incision through the vaginal mucosa, then you dissect out underneath here the layer of strength, which is the fascia, and you bring that together. You trim off the excess vaginal mucosa, and now the bladder is supported anteriorly. You can do a posterior colporrhaphy and support the rectum as well. So this is the surgical repair if symptoms are severe. Now, what if a patient has one of these procedures done and she gets pregnant? The weight of the pregnancy, particularly with labor and delivery, could tear this through. So this might be an indication for a scheduled cesarean. All right, let's summarize with some pictures. Here you can see is the vagina, the bladder, the rectum. Notice the orientation of the uterus, and it is well suspended up high. No prolapse at all. Here we can see there is anterior vaginal wall prolapse with the urethra, cystourethrocoele. On this one, we have normal anterior vaginal wall is a posterior vaginal wall. This is a rectocele. This is the enterocele, and you can see between the posterior uterine wall and the rectum, small bowel prolapses into the sac here. Here we see uterine prolapse, and notice the change in the angle of the uterus as it starts coming down. Uterine prolapse. If the patient has medical complications, say chronic obstructive pulmonary disease, coronary artery disease, not a good surgical candidate, you can use a pessary to hold the uterus back into its normal position. Or you could suspend the uterus with a If the uterus is removed previously and you have vaginal wall prolapse, this is what it would look like. And you can suspend the vagina to the sacrum with a sacrocolpopexy.